Okay, so it's 1 minute past 6. Good evening, everybody. On behalf of the Medartis, I would like to welcome you to Webinar Wednesday and thank you very much for joining tonight's session. It is my pleasure to introduce our speaker. A warm welcome to Professor Chlodwig Kirchhoff from Munich in Germany and to David Dixon from Bradford in the UK, who will discuss new treatment options for dislocated wrist fractures using the APTUS spanning plate. Just before we start, a short comment from my side. To ensure the best streaming quality, I would like to ask you to keep your microphones on mute and your camera switched off. Please feel free to ask questions anytime in the chat box, which you can find at the bottom of your screen, and we will answer them at the end of each presentation. The webinar is being recorded and will be available on the Medartis YouTube channel over the next couple of days. So again, thank you very much for joining us tonight. And now it is my very pleasure to hand over to Chlodwig, who will do the first part of the presentation. There you go.
Thanks, Helene, for the introduction. Welcome to the audience. I just open my presentation. And yeah, the topic is spanning the wrist. And I'm trying to give you my point of view as a trauma surgeon, not as a dedicated hand surgeon, but as a trauma surgeon. And I'm really looking forward to the discussion and your critical questions. I want to start with a case you maybe found on the Medartis LinkedIn portal. We talk about a 68-year-old lady. She's not geriatric because she fell during her daily Nordic walking tour, but she suffers from osteoporosis with a T-score a couple of months before of -3.5. She takes some medication for her osteoporosis, and this is the X-ray. You see it's a C fracture with a larger comminution zone on the dorsal aspect. We performed a CAT scan, and you see it's not an easy fracture. Some will advocate to just put on a plaster cast after reduction, but she's 68 and active. And so one of my colleagues performed typical volar plating. I think the reconstruction he realized is pretty nice. You can say, well, the plate has to be aimed a little bit more distal. Maybe she's still in a little bit of dorsal tilt, but generally it's not a bad reconstruction. And due to her bone quality, she received a restricted protocol for rehabilitation. She was put in a cast for 2 weeks, and after 2 weeks, she was allowed to start moving out of the cast without load bearing. Yeah, and then she came 6 weeks after to the outpatient clinic, and you see what happened. Yeah, we have a screw cutout, the whole construct failed. We have a posterior dislocation of the wrist with respect to the distal radius. Yeah, and here I stop with the case. You think about it, you make your own plan how to revise it, and then we will meet the lady at the end of my talk again. Yeah, spanning plating is not really new. There are 2 case reports out of 1998. One is from Berkey and Singer, and they published it in Techniques in Hand and Upper Extremity Surgery. They used a general straight LCP plate. They made their concerns, or they already had their concerns about the PL tendon and about Listus tubercle. And when we talk about spanning plating, it's first a discussion about the real indications for surgery on wrist fractures. So generally, renowned indications for conservative treatment are a radial shortening lower than 4 millimeters, an articular tilt less than 10 degrees, and the typical articular step off of less than 2 millimeters. Of course, there are lots of more points to respect: AO classification, instability criteria, whatever. But I think we can reduce it to a couple of things when we can go for conservative treatment and when we have to think about surgery. Generally, we have three groups of patients and some gray colors in between. First group are young, often male patients with high energy traumas. Often they sustain multiple injuries, or these are occupational injuries. And for the initial treatment in multiple injuries or bad soft tissue envelope, we often talk about X-fixing, and finally about volar plate. We have golden ager patients. They suffer from osteoporosis. They are in between 65 and 90 years old, but they still have high functional demands. And for these patients, treatment is not so difficult, so easy to choose. Finally, we will end up in volar or dorsal or combined volo-dorsal plating. And then a high group is the real geriatric patient who suffers from comorbidities. And there are enough publications and enough surgeons who say, okay, the ideal treatment for these patients is a plaster cast. But think about the old ladies in their nursing home. They want to go out on a rollator, as we call it in Germany, on a wheeling device, and they need still their hands and their wrists for getting stability, either on crutches or on their device. So maybe the plaster cast is still not the best treatment for the geriatric but mobile patient. Yeah, treatment options, as I said, besides conservative, it's operative. We start with minimally invasive things, just like K-wires, either according to Kapanji plus Wilnegger or whatever. We go over to the X-fixing and then combined plating maneuvers. What are the indications for external fixation or external spanning? There are some strong and some relative indications. Strong indications, of course, these are highly comminuted fractures, very distal intra-articular fractures, significant bone loss, open fractures with extensive soft tissue or neurovascular damage. Relative indications, these are often the initial very swollen ones, ipsilateral elbow or shoulder injuries, and all kind of revision things due to infection. And as I said, the multiple injured patient. What are the drawbacks of external spanning? Sometimes the ligamentotaxis by traction alone is not really sufficient. Often you need an additional K-wire or a couple of K-wires for really getting an anatomic tilt. And hand on your heart, the complication rate when you want to do a definitive treatment using an external fixator is high. You have iatrogenic metacarpal fractures. You often injure the superficial radial nerve. You have pin tract infections, and over distraction using an X-fix is pretty easy. We go over to internal spanning, and so the potential benefits of a spanning plate. You have additionally buttressing effect on the dorsal side. Sometimes, or most cases, you need less distraction. On the one hand, you have the surgical site infection risk, but you have no pin tract infections. You have, and that's proven by a couple of good publications, a higher biomechanical stability in comparison to the X-Fix and for the patient. And that's in Western countries, I think, of distinct impact. You have a higher patient comfort. When you go to to the PubMed and just look for spanning plate and distal radius, it's only 39 publications. And I just want to give you two papers on your hand. It's one from Alexander Lauder. It's published in 2015. And he reported on his results using spanning plates. And when you see the right table, and especially the motion degrees of uninjured versus the operative group, it's astonishing how good the patients do after removal of their spanning plate. It's really astonishing. A second paper, to be fair, is just focusing on complications associated with spanning plates. This one is from Douglas Hanel, and he reported on 140 patients with 144 fractures. And he used not a dedicated spanning plate. This was just a 2.4 mandibular plate that was used as a spanning plate. So it's not really a stable construct. But in total, in this big group with really difficult patients, he had 10 major and minor complications. So that's not a huge number in 144 fractures. Yeah, let's go over to the Medartis product. It's a 2.5 plate that supplements your 2.5 set. And the first question you have to ask yourself is whether you have to address the third or the second metacarpal. And I think it's not surgeon's preference. It's more dedicated to the worst pattern of your fracture, whether your worst topic is more on the radial or more on the intermediate or ulnar side, you know. So for the radial column, I prefer the second metacarpal, and for the third, for the intermediate ones, the third metacarpal. And still, don't think it's an absolute standalone procedure. There will be cases where you should really take additional maneuvers into account, just like K-wires or an additional volar plate. There's a nice paper on the technique from Hanel published, and it's a couple of years ago, and he had distinct concerns about the ECRB and the listus tubercle. And Medartis developed this sidewinder plate to address the third metacarpal and to really solve this problem. Another topic besides choosing second or third metacarpal is the inclination of the hand. And when you just focus on the maximum grip force you can develop, depending on the flexion or extension degree of your wrist, you will see that a little bit more extension is better for your grip force. And that's what was respected when you see the design of the Medartis plates. They all produce a little bit of extension, and they all buttress not only the dorsal aspect of the radius, but also the first row. Yeah, the procedure, when you made all your decisions, is really pretty straightforward, at least from a trauma surgeon's point of view. When you made your decision whether you want to address second or third, you open your implant, and then I usually use an image intensifier, place a plate in a proper way, and then I sign my incisions. And then I usually do the proximal and the distal incision simultaneously. And for the proximal incision over the radius, I prefer to go a little bit more radial, not dorsal. So when I need it, I can use a clamp to place the plate on the radial bone. Here you see a 45-year-old lady with a very distal fracture. And in this patient, we used a second metacarpal plate. And this is the official Medartis video. I'm sorry, our legal department currently is pretty strict with patient videos, and I have no signature from the patient with my videos, so I use the official Medartis video. You see, you have to slide in the plate from distal to proximal due to this tilt over the first row. Then I usually start with the oblong hole on the metacarpal, adjust the plate to the metacarpal, and fix the construct to the whole metacarpal. As I said, it's all 2.5. You know the implants pretty well when you use Medartis. And the next step is the reduction of the fracture. So I use ulnar inclination. I really reduce the fracture. Usually you should start reducing it before you open up the wrist. And then I place another golden screw into the oblong hole, and so that I can still put a little bit of distraction if I need it on the plate. Then I do another image intensifier control in 2 planes. And when I think that I still need a little bit more spanning, I can open up the golden screw, tighten it again after a little bit more distraction. But still think about over distraction. This can really make problems to your patients with regards to stiffness and post-operative mobility of the joint. What are my indications? I think it's not typical trauma surgeon like. There's a fracture, I have to fix it. It's really about individual patient-centered indication. In patients with highly comminuted intra-articular fractures where I think I'm not able to do it with a good volar or combined approach using plates, I'm thinking about spanning. In patients that have distinct demands on their wrist function but suffer from severe osteoporosis, I'm pretty fast with thinking about a spanning plate. There are, even in young patients, very far distal, I call it slice fractures, where you cannot put a single screw into the distal joint block. There you should think about spanning, internal spanning. Radiocarpal fracture dislocations, where we previously did our ligamentous repair and then put in some K-wires. They are, or an X-fix, they are really a good indication for spanning plate. And patients with multiple injuries that have severe problems of their lower extremities, that need mobilization, that need stable wrists, they are also, in my view, good candidates for a spanning plate. And patients with bilateral distal radius fractures, where you maybe want to give the perfect function to the dominant side, and you're happy when the other side can use the fingers and lift weights. There is also place for spanning plate. We get now back to my initial case. And yeah, I think my solution became pretty clear over the talk. The bone quality is bad. It will be pretty hard due to the bone loss caused by the screw perforation to augment it and to maybe put on a dorsal plate. I think I say there will be colleagues that say, okay, now I do a combined procedure. I augment the joint from posterior with autolog or allogenic spongiosa. and then I perfectly reconstructed, but not in my hands. So I just removed the proximal volar screws. I left the volar plate as a buttress, and then I spanned the wrist onto the third metacarpal, but I opened up the joint block because it was 6 weeks old, and I lifted it using an elevatorium or, using a device. I lifted the joint block and I put in some allogenic bone, and then I spanned it. And usually we remove the spanning plates after 12 weeks. Currently, we have really problems to get the patients back within these 12 weeks. We lose them due to the pandemic situation. And I have a couple of patients where we removed the spanning plate after 5 or 6 months, because the old ones, they don't want to return to the hospital due to COVID. And just in this revision case, we also removed or had the chance to remove it after 5 months. And unfortunately, the film does not start, but on the right side, you see at least how the extension of the wrist works, and the dorsiflexion, the volar flexion is not as bad as some people will expect it after 5 weeks. And I think it's after this whole thing, not the worst joint after my revision. Yeah, and I'm already at the end, and I thank you for your attention. And Helene, we will discuss both presentations afterwards, or shall we discuss my presentation now?
I think we can do this already. So if David, if you have some comments to this presentation, maybe, or anyone in the audience, please feel free.
Great presentation, Chloe. Actually clears a lot of stuff in my old mind, if I'm honest. I think the thing that, to come on to your last point with the delayed plate removal, I don't know how you found it with those ones that you've left in longer. We have had a few for either the patients disappeared for a long period of time. We've had a couple of patients that have gone back to Pakistan and then for 6 months or more. We've also had a few issues with the pandemic. We've also had a few issues with patients not being fit for other reasons to come back to theatre. We've ended up with a few plates out even at a year, and I'm amazed that the wrist still moves, but it does. So that's the one thing I would encourage people who are skeptical, is even if you can't get it out as early as you might want, the wrist still seems to be forgiving, bizarrely, moving it many, many months, even up to a year later.
My very first 2 spanning plates are old ladies out of a nursing home using crutches, and I saw both of them a couple of weeks ago, and they don't want to get the plate removed because they say, oh, I have such a great stability in my wrist and I can use the crutches much better and pain-free than before. I tell them, okay, earlier or later, the plate will get loose on the metacarpal, and then we have a huge problem, but still I cannot convince them.
Yeah, well, I'm pleased you've had the same problem, but we've had a couple of patients similar, where they're so satisfied with it, which is bizarre, because normally when you fuse someone's wrist, they miss the movement, and yet somehow when you span it for fracture, a number of patients, I think probably because you're dealing with that older age group in the scenarios we're talking about that have a lower demand, they don't miss the movement as much.
So for the moment, there are no questions in the chat function, but I saw we have Wolfgang Hintringer in the audience, and I know that you had some comments already on the LinkedIn discussion. Maybe you would like to contribute in this meeting.
Thank you for the nice presentation. I'm here in Egypt, in Soma Bay, in my holidays. I saw this case in LinkedIn, and so It was a pleasure for me to discuss that case. So I think what you said is right. We have a lot of indications, but the first case should not be the indication for a spanning plate, because a not really good mounted blade and the wrong blade for this fracture cannot be the indication for a spanning plate. Yes, as revision, it is a good idea, and it's also the outcome is really nice, but we have to focus on cases which need really the spanning plate. And this one I would have plated from volar with a very wide distal reaching plate, maybe a frame plate or something else, and the second plate as a buttress, and the better position of the screws would have maybe not come to this end. Yeah. So anyway, I think more and more we should take this plate in our mind and not do open surgery if we know that we cannot, as you said, address the fragments. Yeah. If we primarily know from the CT scans that the fragments are addressable and that we have a solution, then if you are a good hand surgeon, you should try it. But anyway, there are a lot of indications now where plating fails.
Wolfgang, you're absolutely right, and you're an excellent hand surgeon. But you also know that the real reality in the world, in Germany as well as in Austria, is that a general trauma surgeon thinks, okay, it's a distal radius fracture, and I do my standard procedure. And you, I think, will have seen much more cutouts on the wrist than me, for example. And I think it's more about a general view on the things. Is it better to allow a general trauma surgeon to put on a spanning plate and thereby prevent, especially in fractures as I demonstrated, the complication, or maybe just to make a wider audience for this plate? You get my point?
Yes, yeah, sure, it's right. I think that plate is not in our mind now, yeah, because we have learned to operate all fractures, and but I think we have to get familiar with this plate and to prevent wrong indications for fractures which you cannot operate with our normal plates. Yeah, you're right.
Yep.
Thank you very much for jumping into the discussion. And we're just perfectly in time to hand over to David. So if you stop sharing your screen and David starts too.
Okay, no, sorry.
That looks good. You're still on.
Yeah, there we go.
Now we can see your screen and hear you.
Lovely. Okay, so I've called mine a sort of a spanning plate fixation because the first time I came to it, my entire response was, well, why would you? So hopefully we can try and, my aim really of the talk is to walk you through the learning curve I've been on. I am a consultant surgeon of 5 years at a district hospital. I want to make it absolutely clear I'm not a world expert. There are plenty of better people out there than me. But I'm naturally a skeptic, so I'm not someone that looks at every new thing that's going on and thinking, all right, well, I'll try a bit of that. So my talk is very much on the experience I've had and what I've learned. To declare, I do use a Medartis kit, and Medartis currently hold the hand and wrist contract in my hospital, but I haven't received any financial benefit from Medartis. But I am very grateful and honoured to be sort of talking to you, and hopefully there'll be a very interesting discussion afterwards. So as I said, the first question really is, well, why would you? You know, you only need to open any of the catalogues, and Medartis one in particular, and see a larger range of plates, sizes, designs, and you look at it and go, well, that covers pretty much every fracture configuration I can think of. You know, if we span a plate, then essentially, if we do a spanning plate, then essentially we're delaying the functional recovery. The wrist can't move. Their functional impact is significant. They're going to have a permanently stiff wrist. And you're signing the patient up for a compulsory second procedure. So those are very much the thoughts I had about spanning plates as I started. Fix and forget is a term that I sort of grew up with through my training in the UK, which was, fix it, put it up, you never need to worry about it ever again. You don't need to see them every week. And you know, as I said, there's such a wide range of plates. I didn't really see what the point in doing a spanning plate was. And my other point was, you know, it would feel like admitting defeat that I was unable to fix this. So my mentality for the difficult cases, such as the one on the left, was employing a combined volar and dorsal approach and getting a reasonable restoration. There's clearly a little bit of the intermediate column that's flicked out from the plate there, but functionally they do well, and you think, well, that's not going to go anyway. So in your mind, like everything you do in life, the more you do something, the more it reinforces that it seems to be the right thing to do. So in my mind, it was always right, well, it works, doesn't it? So just carry on doing the same. So I spent a significant period of my time often starting with a volar plate in a buttress type mode for these, and then approaching dorsally to reduce the fracture in the joint surface on, and then sometimes putting some supplementary screws in and thinking, right, well, almost patting myself on the back at the end of the case, going, well, that's great, that's stable. I've screened it under the image intensifier. I've got a good fix. I've put some bone graft in. What can possibly go wrong? Well, you'll have all done enough of your own cases to know that, well, perhaps even when you've done that, it still doesn't work. So this one, despite what I thought was a good fixation, the use of bone graft, we lost the position. We ended up with metalwork problems, and we ended up with a second operation anyway. So that was the sort of the first starting point of thinking, right, well, you know, maybe, you know, I can't fix everything. But then you have a night's sleep, you wake up the next day and you say to yourself, yeah, but complications happen. Loss of position happens. You know, it was one of those scenarios, and it's better to have an occasional second operation than spanning it and forcing the patient to have one. So the next sort of osteoporotic fracture that came in was this one, and the eagle-eyed amongst you'll see that the reduction in A&E from the top films to the CT scan shows that it was purely dorsally unstable originally, and then following the manipulation, it's also now slipped partly off the front as well. But she's 63, she's fitting well. But I think the one thing I would point out on the CT before I show you what you probably all guessed is going to happen is the minimal amount of cancellous bone on that CT scan. So, you know, there's a big void. There's nothing really there. But I went to my tried and tested method. Here's the intra-op films. You know, I went very distal with the plate on the dorsal side, but we got a nice restoration. And again, you know, it was stable. I put some bone graft in because of the void and gave myself a virtual pat on the back on the way out of theatre. But then she comes back at 6 weeks and it's collapsed. You've got screws in the joints. You're disappointed. The patient's disappointed. So we ended up going back to theatre, but it was only 6 weeks. I was a little bit skeptical about taking it all out. So I thought, well, I'll just take the distal screws out. You know, it's going to have collapsed as far as it's going to. I'll just take the distal screws out and we'll allow the rest of it to come up as it is and see where we are. So that was at 6 weeks. And then she came back at 6 months and lo and behold, it's collapsed further. You know, you can see on the lateral view that actually the joint surface isn't too bad, but the whole lot has collapsed en masse. And now that dorsal plate essentially is blocking wrist extension, so she can't extend her wrist past neutral. Added to that, the tendon irritation. So we end up with a third trip back to theatre. So then you start to go, right, well, if I had my time again and I could go back to the beginning, what would I do? I don't think I could have treated it non-operatively in a 63-year-old. This case, if anything, pushed me more towards thinking about spanning plates. So I think my learning point in my first year or so as a consultant was, right, well, non-spanning fixation still results in significant secondary procedures. And maybe that spanning is better in those lower demands or osteoporotic patients, multifragmentary, and having some of those lower demand patients almost saying to yourself, right, well, you know, it's dislocated, it's multifragmentary, let's just put the hand back on the end of the arm, really to try and maximize their forearm rotation for function and minimize their all-decided wrist pain. So here's the start of my learning curve, if you like. This is an open fracture in a 78-year-old osteoporotic, but a very active lady. She's got a clear comminuted fracture intra-articular. As Clodvig was saying, for one of his indications, it's quite distal, particularly in that intermediate column. She came in on a weekend and she had an external fixator applied by one of my colleagues. The wound was managed. The wound was only on the volar side. It was essentially a relatively small puncture type wound. And we thought maybe we'll sit on this and just see if the X-fix will serve as definitive management. But lo and behold, the X-fix starts to loosen, the fracture position starts to drift. And, you know, I'm then left with, right, well, there's a bit off the front, there's a bit at the back. I'm not going to be able to get this just from a volar or a dorsal approach. I probably will have to do a combined volar and dorsal, and then she's going to need another incision for the ulnar. And I didn't really fancy making 3 incisions on a 78-year-old with who'd already had an open fracture. So at the time, this is what we had in the department. Obviously, this is not a spanning plate. And at the time we did this, there wasn't a spanning plate in the UK available by Medartis or Synthes. But this was the wrist fusion plate that we had on the shelf, which is the Synthes one. And we use this essentially to span. You can see on the lateral view that you've got to position it pretty well so that that third screw on the metacarpal is just distal to the CMC joint. That gives you the maximal length then onto the radius. But I think in terms of achieving what we wanted, we got a reasonable length, we got a neutral volar tilt, and she went on and did pretty well. So, you know, it then sort of reinforced me, right, well, those ones that you're considering an external fixator, you know, we often have pin site problems, we often get loosening or even loss of positioning, particularly in those osteoporotic bones. And maybe, just maybe, the spanning plate could have been used instead of the X-fix in that emergency setting, given it was only a small wound over the volar side. I think as Clodvig sort of alluded to, you know, these aren't ones that you would go and do on if there was, you know, significant soft tissue problems or contaminated wounds. So the next case that I then took on was this lady who's overweight, significantly overweight, She's 62 years old. She's got an intracapsular hip fracture with this comminuted intra-articular fracture, which we didn't really think was reconstructible very easily. And secondarily, it was then, well, what fixation are you going to put on that's then going to enable her to mobilize afterwards? So this seemed a relatively simple one to repeat the same story on. So we again used the wrist fusion plate, and we used the femoral head as an autograft, and we allowed her to then mobilize with forearm crutches. But as I alluded to previously, the plate was then left in for 12 months due to medical problems. But despite that, she still ended up with 40 degrees of extension and 30 degrees of flexion, which even had I gone and done a combined fixation on, I would have been happy with that range of motion, to be honest. The problem with that plate was very much that there were times it wasn't long enough. So the next case we had was this one where there was some metaphyseal comminution, and we tried to put a wrist fusion plate on, but it just wasn't long enough. And the only bailout I had was this 3.5 millimeter LCP, but as you can see, it's absolutely huge on the metacarpal. I was concerned about a metacarpal fracture. Thankfully, that didn't happen, but she did end up with an EPL rupture as it runs over that very thick plate over the wrist. So that really pushed me towards going, right, well, I am doing spanning plates and we need to have something better. So the next time we had one in, again, osteoporotic, large bone defect, comminuted, intra-articular, but with the metaphyseal comminution that you can see, particularly on that CT scan. We finally managed to get our hospital to agree to allow us to have another company. As I said at that point, now the Medartis and osteosynthesis had one, and we got this one in. And this plate worked very well. It worked nicely in the sense that you've got the plate that you can slide in, very similar to the Medartis one. The plate lined reasonably well over the intermediate column, but it's got quite a broad part, but the screw settings aren't really very useful. So the holes that are there for the around the distal radius fracture weren't particularly helpful. And whilst this mightn't be the prettiest of looking x-rays, it allowed the hand essentially to be on the end of the forearm, and she regained reasonable flexion extension, but good forearm rotation, which I think is one of the key parts. So the next case is looking at this 76-year-old, known osteoporosis. You know, looking through the 3D scans, you're left with a significant ulnar fracture and radius. Again, is this going to be something you're going to use maybe 3 incisions on? I wasn't particularly keen, and I was getting a little bit of confidence on doing some spanning plates. So we used the same spanning plate technique. The thing that I wanted to allude you to here is that the straight plate, and I accept what Klodvig said in that you can adjust how you line it up, and it may be that there's been a little bit of user error here and I could have positioned it better, but we didn't really get very good cover on the intermediate column, and it ended up needing a supplementary KY to try and hold a significant piece of bone in. So as I gain more and more, I now warn a lot of my patients that they may end up with a spanning plate. And even if I plan not to span, that I put that in. And there was this patient, as you can see, with an ipsilateral elbow dislocation, young patient, high energy injury. And my initial thought was this might be something we could reconstruct without spanning. But when we got in there, as you'll see from the post-op films, there's a very large bone defect with essentially a wafer of a wafer-thin piece of joint surface in the intermediate column. And I didn't really feel it. Either A, I could get a screw into that to hold it, and B, my concern was for it to collapse. So we put a spanning plate on. If I had my time again for this, I think I would have used the curved one, which would have overlapped onto that intermediate column better, particularly as I supplemented it with a radial column plate. He is now, I think, 8 months. And where we work in the UK in Bradford, we have a very large Asian community who, even during the pandemic, a significant number of people have been going backwards and forwards to Pakistan. So we are awaiting for his return from Pakistan before we can take his plate and screws out. So this is a case of my colleagues in Bradford, which I wanted to put on because, and I must point this out, that this is a case of, this is probably one where Medartis will wash their hands of, in that this isn't what they would encourage you to do. But as you'll see, when I started, we used a wrist fusion plate, and my rationale for using those is it's relatively short. The spanning plate is great in the right patient, but there are times when it's such a distal fracture that you sort of feel you're doing quite a significant amount of dissection. And by the time you've opened up at the fracture site and put it on, you don't really want to be doing any more dissection to put a long spanning plate on. So this is a colleague of mine, a 50-year-old nurse. She fell down a flight of stairs. She sustained bilateral wrist fractures. And essentially, we got a 3D scan, felt that this was somewhat comminuted and quite distal. And this is what we did. We put a spanning plate on, but we used the Medartis total wrist fusion plate. Again, I'm sure Medartis will, this was our choice. This wasn't something Medartis encouraged us to do. But that's her, essentially, with removal at 3 months and her at over a year following injury. That's her outcome. And then for completeness, this is my latest case, 77, fit and active, a very significant distal forearm fracture. Didn't feel as though it was something we could treat non-operatively. And this is one of a few now that I've done where we've used the curve plate, and the curve really does give you a lot better hold straight over that intermediate column. And the other part, which Coving has already alluded to, is the curve on the plate, not only going over the intermediate column, but also giving you some wrist extension, which really helps twofold. One is the wrist is a little bit stiff and extension, it gives them better use. But secondarily, the thing that I've found when we span the wrist is often tightness in the MCP joints, and there's been a few patients that have really struggled initially to regain flexion. So the key bit really is by giving them a little bit of extension, it helps to try and get those MCPs moving a little bit better. So these are my thoughts for what they're worth. I see the spanning plate as part of my armory in managing wrist fractures, but it's not for every comminuted fracture. I don't think, unless you're at a major trauma center, you're likely to be doing many. I've so far been doing probably 4 or 5 a year, but I think probably that will only go in one direction, which is I'm likely to be doing more. If you can do a dorsal plate, you can certainly do a spanning plate. It's not particularly difficult. I think I would encourage you to consider using these instead of an external fixator. You don't get the pin site problems. And the other beauty is you can leave the plate in until you're happy that union has occurred. which in my experience with external fixators, you're usually having to take it off while the fracture is healing, not fully healed. It's maybe a little bit sticky. You wrap them up in a plaster for a while. You know, the beauty, as I say, with the plate is you can leave it in until you can comfortably find a time that it's healed and take the plate out. But like an external fixator, you must be mindful over distracting. But I do think this is less of a problem than it is with an external fixator. I think if you've decided to fix a comminuted intra-articular fracture rather than treat it non-operatively, and they're osteoporotic, I think you should consider spanning them. There's a significant number of these that end up with loss of position, screw cut out, secondary operations in any case. And I think the beauty with the spanning plate is you've got a relatively more predictable outcome for you and the patient. I would consider using it in large bone defects. You can combine it with other techniques such as buried wires, radial column plates, distal ulnar excisions I've done. And I think the other beauty with Medartis is you've got the options of both the curved plate over the intermediate column and also a straight plate as well, depending on what your fracture personality is. And that's the end of my talk.
Thank you so much, David. We just had one quick question in the chat. Would you agree to Chlodwig's answer of the question of at what percentage of the patients do you remove the plate?
Yeah, I take them all out. The only exception being one or two patients that have declined to come back. Some of those have been because of the pandemic, and I anticipate that they will come back once they've had the vaccine and the numbers are down. But yes, I don't plan to leave any of them in.
Right.
It's funny, although we did not talk before our talks or before our presentations, our philosophy seems to pretty similar.
Well, the thing for me is I've borne my warts and all by showing you the journey I've been on, and I'm sure plenty of you sat listening to it will go, well, he didn't need to go on such a horrible journey of failures to get to this point. But hopefully it shows you and shows everybody watching why I now span on occasions rather than just thinking I can fix everything. I've tried that, and you know, it doesn't work every time. Not in my hands.
I have one question. When do you remove the spanning plate? After, in general.
So I always tell them that it will be in for at least 3 months, but I very much wait until I'm convinced that we've got solid union, and I have no real issue leaving it up to 6 months. I get twitchy after 6 months, but as I say, I've had a few where it's been left in for various reasons for a year. And the bizarre part is how it moves. And I don't understand that, because if you wrap someone up in a cast for a year, you would never tell them that the wrist's going to move again. If you wrap somebody's knee up in a cast for a year, you tell them it would never bend again. And yet, for some reason, for which I don't understand, it does seem to work.
Yeah.
It does seem to me.
Next question, volar plates or dorsal plates, general dorsal plates, you will remove after how many months?
So just a non-spanning dorsal plate?
Non-spanning average dorsal plate.
I don't, unless there's a problem.
Okay.
So the rationale here in the UK is you've got to really, you know, for the NHS is very much, you know, there's got to be a strong reason as to why you've got to take the metal work out. So unless there's a tendon problem, there's a screw ended up in a joint, then the plate stays in and they live with it for the rest of their life.
The thing about Germans is, I don't know where it comes from, but here in Germany, almost every patient, even when he's 80 years old, desires plate removal. And you really have to convince patients that it won't make any difference when you leave the metal in. So we really remove a lot of metal work. And the average time when we remove it is always something in between 7 and 12 months. And there is no real rationale in the literature when it's safe to remove a plate, but most papers will say make it dependent on the X-ray, but earliest half a year later or 9 months later. And
so certainly in the UK.
Sorry, let me finish.
Sorry.
But, the spanning plate, where we still have difficult joint fractures, we remove after 3 months without any problem. That's the funny thing. So I think when patients desire a plate removal of a volar, a locking plate or a volar plate, maybe it's even safe to remove them when the X-ray is okay as well after 3 months.
So I guess for you, one of the points in my talk is somewhat different in that for me, if I span somebody rather than don't span them, I know they're going to have a second operation. Whereas if I don't span them, that's not a guarantee, and I will do my level best not to operate on them. So there is a difference there. If you know that you put a dorsal plate on, you're pretty well guaranteed to be taking it out. Then I guess, and that's the culture you live in, then I guess putting a spanning plate on is even less of a problem because you're going to be taking it out anyway.
Yeah, right.
I have another question from the chat box. Maybe the first one to David. Do you slide under the second compartment or on the fourth, if I get that right?
Oh, I see. So I make a little bit like clubbing. You've got to make a decision as you start as to whether you're going to line onto the index or the middle finger, and whether your main problem is essentially over the intermediate column or the radial column. In my experience, it's nearly always the intermediate column I'm putting the buttressing effect of the spanning plate on, and I'll add in a supplementary styloid plate on or some other fixation of that radial column if need be. I do try to make it minimally invasive, but more often than not, I do end up making a relatively large incision to try and slide it through. I did have one case of a patient in severe post-operative pain the following day, and I thought I must have trapped something under the plate because I hadn't opened it at the fracture site, and I thought, right, it must have ended up on top. And I opened it up and there was nothing there. So I now have a slightly low threshold for opening up at that sort of fracture site and making sure that the plate is where I think it is. In answer to the last question from Philip Matthew just gone on, if I do open the back of the wrist and I'm near the PIN, yes, I cut the PIN.
Would you agree, Klodvik, or do you have another opinion?
Nothing to add.
So
really.
that's okay. So, maybe you can take the other question. Can you point out some differences between the curved and the straight spanning plate?
Yes, of course. Hello?
Yeah, we can hear you.
Okay, he's gone. Looks like maybe David, you can take over the answer.
Oh,
the
okay.
Difference between curved and straight plate until he's back.
So both of them have a dorsal curve on them to increase, to hold the wrist in slight extension. The curve essentially helps you to rotate the piece very much over the intermediate column and to the ulnar side of Lister's tubercle. The thing I like about that more than the straight one is it really perfectly overlines that intermediate column. And And those bits where you, so often in some of these fractures, you've got what my colleague, and I hope this translates well for you all, but my colleague refers to as a cornflake. There's a very small piece of bone, very much on the ulnar side of the dorsal aspect of the wrist, which is so thin, there's not much you can do, whereas that curve that comes around beautifully buttresses and holds that down. The straighter plate, the one that doesn't curve around onto the intermediate column, does give you an ability to bring it further across onto, if your comminution, your problem is slightly more radial or into that radial column.
All right, thanks. I have one. Yeah, please jump in.
Yeah, well, there was a discussion about removing the plate. You were talking only about removing dorsal or also volar plates, because I think removing plates, we have to discuss the indication when it's necessary. Yeah, you cannot say I don't remove any plate, all stay in, because if you have a plate on the volar side, which is maybe mounted very wide distally, and you can be sure that he will get a tendon rupture, then you have to say to the patient, you have to get it out. Yeah. If the patient comes after 3 months and he says he has pain in the thumb when he is flexing it, you have to put it out. If you have a Song 2 mounting of the blade, you have to put it out. So I think the indication is important when you put it out or not.
Yeah, sorry, I maybe haven't clarified my position well. What I mean to say, and hopefully I'll say it better this time, is I never plan to take out a non-spanning plate. So I don't go in and do a volar or a dorsal or a combined plate with my rationale that this is going to definitely come out later, unless either because of the fracture or, you know, how I've put it on, the plate is just sitting off a little bit. So that's been a technical error by me. Or, as you rightly say, there are post-operative reasons to take it out. So if they have a tendon irritation, if there is an infection, to take it out. Then, you know, or there are screws that have ended up in the joint, the fractures moved. They're all genuine reasons to take it out. So I'm not saying I never take a plate out. I've taken plenty of plates out. The point I was trying to make with Clodvig was, it sounds as though, and again, I may have misunderstood it, but it sounds as though the culture, certainly where he works in Germany, is that it's pretty much a routine to take all plates out, which is not what we do in the UK. And I'm not saying one's right, one's wrong, but we very much work on the basis that unless there is a problem with the plate, either because the patient's got symptoms, or you look at the plate and you think there's going to end up with an FPL rupture or something, I don't routinely take them out.
Okay, Jodwig was not here while we were talking about putting out plates, but you know, we have different plates, and the first plates of Medartis were radial oriented plate, and they needed to get out much more often than the plates what we put in now, like the FPL plate or the adaptive plates which stay under the watershed line are plates which you can let inside. But anyway, there are a lot of hospitals who have only one plate, and that's the foot plate or the reconstructive plate. Yeah? And they should think about ordering other plates which can stay in.
I think the other thing I would say with the Medartis system is I think even their dorsal plates, the profile that they have with them, and again, I'm not taking any backhander on this one, but their profile of their dorsal plates is so much thinner than what we used to use, that
yes,
the number of dorsal plates I'm now taking out, I think is less. And I don't think that's just pandemic related. But only time will tell. But I don't think I'm going to be taking out as many dorsal plates as I used to.
Yeah, for a lot of surgeons, taking out dorsal plates is because I don't know if there is any paper over that they get more motion in volar flexion if they put out the dorsal plates. Yeah,
I have. So anecdotally, those that are stiff in terms of palmar flexion, we have a chat. I have a chat with the patient. The patient's very keen to try, but I would say it's very much a mixed bag. Some come back and they're very happy. They've got quite a bit more. Others come back and there's no difference whatsoever. I think you could almost toss a coin.
Okay.
Anything more to discuss?
Well, I didn't say something to your talk, David, and it was really nice because you showed us the cases where we should use spanning plates, because we always try to fix all, maybe from both sides, even when we think we cannot address the fragments. And that's the really indication for spanning plates. We have to make a good analysis of the CT scans and really think about it if we can, with our plates, have a secure fixation of the fragments. And if that is not the case, then we should use spanning plates. That's what I wanted to say.
Yeah, I think the learning point that I've made, which, I accept some of this is me, in my hands, I have tried my best to try and not span. And I've used lots of combined volar plates and they work well. But I've had a number of very bad failures. And it has very much led me to think, well, actually, what am I trying to achieve here? Am I trying to make something that looks radiologically beautiful and that they can get it moving? Or am I just trying to put the hand back on the end of their arm so that they've got pronosupination and they've got no undersided wrist pain? So you look, even when, if you want to be critical about my spanning plates, lots of them are far from perfect. But all I've tried to do is basically align the hand back on the end of the arm so that it heals in a means that will give them some function and hopefully minimal pain. And it seems to do that.
I think what we should not do is, if we don't want to operate, putting in a spanning plate. So
absolutely, yeah. No, I agree completely. So I made it very clear at the end of my talk, if you've decided to fix the fracture, and this is the key bit, is not, well, I could put a spanning plate on, is look at the patient in front of you, the patient and the fracture, and make a decision, right, is this something I'm going to operate on or not operate on? That has to be the first question. Not, well, I'll just stick a spanning plate on because that's a bad fracture. The first question still has to be the same. Am I going to operate on this or not? And then comes a question, right, well, how am I going to fix this? And my threshold now is only going to drift more and more, I suspect, towards spanning, because the results seem to be better than I would have anticipated. And as I said, I think it's more predictable. I don't know, maybe it's just me, but there's a number of times when I've had a younger patient, there's been a big bone defect, I put lots of bone graft in, I put a plate on, and I've almost done this at home, thinking, cross my fingers and hope nothing's going to drift and fall apart. And more often than not, it's fine. But you only need one or two to fall apart badly, and you think, well, maybe I would have been better just to span it and accept I've got to take the plate out at 3 months.
I think after 60 years of trauma surgery, and especially surgery at wrist fractures, we have in 2021 still no consensus on which fractures we really should operate. Wolfgang, here in Germany, we had the study coming from Ulm that was finally terminated with a question in which old patients we shall do any kind of fracture surgery at the wrist. And the rationale should be that a lady older than 70 always receives a plaster cast because anyways she will do good. And that's not the reality. We have a couple of 100 trauma surgeons in Germany, and not everybody is, just as I said before, an excellent hand surgeon. And all those surgeons have good systems in their hospitals, like a Medartis system. They all have them, but they still have not the adequate algorithms when to use their plates. And that's our duty to really elaborate such algorithms. And within these algorithms, the spanning plate has a distinct position, because out of my view, it's better to do an average spanning procedure at a wrist fracture than a very bad volar or combined volo-dorsal reconstruction try.
Yeah, well, do you know our new or my new classification or our new classification, the eyebrow classification, where we try to give people help, because it is a treatment-oriented classification. And since Medartis has such a lot of plates where nobody knows at what fracture, what plate is useful, we tried to give help with this classification. And I think people who are here should read it. I gave you a link in LinkedIn on this classification, and there will come out a web-based application that you can look for your fracture and get an answer. Shall I do a double plating? Shall I do a FPL plate or a hook plate? How can I stabilize a special volar ulnar corner fragment, and so on? I think we need that because the second thing is, if you go into the operation room, you have to tell the nurse which plate you want to use, because there cannot be all 20 plates on one set. And that means that you have at first to analyze your fracture, have a concept, and then tell the nurse, please prepare for me that type, that type, that type, and maybe a spanning plate for the last opinion which I have. I think that would be helpful.
I think that's a very good point, but also a topic that leaves definitely enough space for another webinar. And we are running a bit out of time in here. If you want, you can just put the link into the chat function so everyone can read through it or check it out on your LinkedIn profile, maybe. Yeah.
I would like to say one thing before you close it off, which is, I know we have drifted off spanning plates, but I think both Clodvig and Wolfgang have made a very valid point, which is, which wrist fractures should we be treating anyway? And, you know, the only good thing I can say that I've genuinely learned from the pandemic is I have treated more people non-operatively because I've had no choice but to. I mean, as you'll all be aware, the numbers in the UK have been terrifying compared to what you've had in the rest of Europe. You know, there was a long spell where even if I wanted to, it was going to be very difficult to get anybody in. And the thing that's amazed me is how many patients we've managed to treat just with an image intensifier in the plaster room down by A&E, and they've done well. And I'm starting to wonder, as I say, we're going a little off piste, but I'm starting to wonder whether accepting a small number of malunions and treating the malunion may be a better option than fixing as many fractures as I do. But that's a cerebral thought that I can't quite get to the end of in my own head.
Perfect closing words.
Yeah, I agree. So if there are no more questions, I cannot see any more. I would like to thank you very much, David and Chlodwig, for your presentations and of course for the valued input. I hope everyone enjoyed it. Sorry that we ran a bit out of time. As I said at the beginning, the recording will be available on our YouTube channel over the next couple of days. And I wish everyone a very pleasant evening, and watch out for upcoming events on the Medartis webinar Wednesday. The next dates will be announced on the LinkedIn channel. And yeah, all the best to everyone and happy Easter holidays, hopefully.